All righty. So tonight we're doing 30,000. So respiratory, there's a little bit of hemic lymphatic, mediastinum and diaphragm stuck in here as well. But then it's mostly respiratory and cardio. So let's do number one. Provider performs a diagnostic thoracoscopy, followed by the thoracoscopic excision of a pericardial cyst. So let's do this one, process of elimination, and then we'll do every other one. We'll do some process of elimination and then some as coding from scratch. So that way we'll do a little bit. So this one, process of elimination, we have two that have 32662. Nope, just kidding. One's 32662, one's 32661. But they're close together. So we can still go to that and see what those codes are. So 32662 is a thoracoscopy surgical with excision of a mediastinal cyst, tumor, or mass. And then 32663 is with lobectomy. Oh, yes, Kristen. It should be, so they're all going to be that way. Accident, because I just duplicated them. So yes, it should be A, B, C, and then D. So if we have the D option is what you're going to choose as an answer, then the second C should be D. Okay. So 32662 is again our thoracoscopy surgical with excision of a mediastinal cyst, tumor, or mass. And then 32663, I'm sorry, 32661. We do have two for 32661. Is 32662 is with excision of mediastinal cyst, tumor, or mass. So we know we need the 32661 because we did a pericardial cyst, the excision of that cyst, right? So 32662 is out because it's not mediastinal. And then we can rule that out, the 32658, because we know we need the 32661. Now, the question is, do we need to report the 32601 in addition? Or do we just report 32661? So 32601 is a thoracoscopy diagnostic, lungs, pericardial sac, mediastinal or pleural space without biopsy. So what does everybody think? Should it be B or should it be um, D? By itself or with, I don't know why it keeps doing that. I'm not trying to do the whole line. There we go. So if we have a diagnostic thoracoscopy that is converted into a surgical thoracoscopy, we should only report the surgical. So our answer is letter D. Okay. So let me end this one and then go to question two. Oh, a patient's nose was hit with a baseball during a high school baseball game. At that time, reconstruction was performed with local grafts. The patient returns now as an adult, discontent with the bony prominence along the bony pyramid and then the flat look of the tip of the nose. He underwent major repair with osteotomies and nasal tip work. So, coding from scratch on this one. Our procedure that we did is this major repair with osteotomies and the nasal tip work. So we need to realize that the procedure that we've done, if we're looking this one up from scratch, is it is a plastic repair of the nose, right? It's a nose job. So our medical term for a nose job or plastic repair of the nose is a rhinoplasty. So in the alphabetic index, we'll go to rhinoplasty. And then we can deduce from everything that we've got here that he had reconstruction done years ago and he is not happy with it. So they're redoing it. So that's going to be your secondary, right? So he's returning now as an adult. So this is going to be secondary. So we need to go to 30430 through 30450. So 30 is going to be a minor revision, 35 is intermediate, and 50 is major. So major is going to include nasal tip work and osteotomies. So yes, it should be 302, I'm sorry, 30450. Okay. Number 3, we have a 43-year-old female is seen in the emergency room with severe epistaxis. She said that this is a common occurrence for her during the cold, dry months of winter, and this is why she's here for the third time this week. Extensive bilateral posterior cautery and packing is again required to control the hemorrhage. So what code are we going to report for the procedure only and not the EM? So process of elimination, you've got 2 that have 30905. They're all right there together, but we can just go straight to the 30905. Control of nasal hemorrhage posterior with posterior nasal packs and or cautery, any method. And then initial. So since she is here for the third time this week, it would not be initial. Oh, sorry. I'm going to end the poll. I need to go to question 3 on the poll for you guys to put in your answers. Okay. So if you put it in just a second ago, go put in your answer again. So then 30903 is control of nasal hemorrhage anterior complex, any method. And then 30906 is that control of nasal hemorrhage posterior with posterior nasal packs and then subsequent. So again, we're here for the third time this week. And then they also did bilateral posterior cautery and packing. So it's posterior, not anterior. So there's just another thing that's telling us that it should be the posterior. Okay. Number 4, we have a 20-year-old that's seen for 5 transbronchial lung biopsies of 2 separate lobes. 1 biopsy is taken in one lobe, and then 4 biopsies are taken in another lobe. So we'll do coding from scratch on this one. We are doing these transbronchial. So that means that our approach, if we're going transbronchial through the bronchus to get to the lungs, that is going to be with a bronchoscopy. So we'll go bronchoscopy. and then we are doing biopsies, right? So we're going to use 31625 through 31629, and then 31632 and 33. So 31625 is bronchoscopy, rigid or flexible, including fluoroscopic guidance when performed with bronchial or endobronchial biopsies, single or multiple sites. Even though we're going transbronchial, we're doing lung biopsies. So the 31625 would not be it. And then we also have 31626 is placement of fiducial markers. We didn't do that. 27 is computer assisted image guided navigation. Didn't use that. 31628 is transbronchial lung biopsies, single lobe. So we've got that, right? In our first lobe, one biopsy is taken. So we know we need 31628. Okay, so again, we're doing this one coding from scratch. So this one's we're not necessarily doing a rule out at this point. And then underneath that, you have two parenthetical notes. One states that 31628 should be reported only once, regardless of how many transbronchial lung biopsies are performed. And then your second parenthetical note states, I didn't change it again. Sorry. The poll. I'm gonna have to get used to changing this every time. Okay, go back and put your answer in the poll. The second one states to report transbronchial lung biopsies performed on an additional lobe, use 31632. So this is going to be our 4 biopsies in another lobe. There you go. Okay. You guys should see it now. So we know we need the 31632, but the $1 million question is, do we use multiple units? Or do we use a single unit for the 4 biopsies in the second lobe? If you don't know and you're just guessing, look at the parenthetical note, the second one underneath 31632. It says you should only report 31632 once, regardless of how many transbronchial lung biopsies are performed in a lobe. So therefore, B should be our answer. Okay. All right. And then the poll for real this time. Then we're going to go to 5. Okay. Question 5. A 25-year-old male presents with a deviated nasal septum. The patient undergoes a nasal septum repair and submucous resection. Cartilage from the bony septum was detached, and then the nasal septum was realigned and removed in a piecemeal fashion. Therefore, your 4O chronic was used to approximate the mucous membranes. Next, the submucous resection of the turbinates was handled in usual fashion by removing the anterior third of the bony turbinate and lateral mucosa, followed by bipolar cauterization. So we have 2 that have 30140, and then 2 that have 30999. Or you could look at it as you have 2 that are very close here in your first. But let's just go do the 30140. So 30140, that is the submucous resection, inferior turbinate, partial or complete, any method. So we did anterior turbinate. Saw it in here. Where did it go? Yep, here we go. So we did the anterior third of the bony turbinate. So that gives us the 30140. And then we need to go look at 30520 versus 30420. So 30420 is a rhinoplasty primary, including major septal repair. And then 30520 is a septoplasty or submucous resection with or without cartilage scoring, contouring, or replacement with graft. So yeah, we did the submucous resection. And then that nasal septum repair, which is the septoplasty. Oh, let me do those different colors. So it's going to be A. Okay. Question number 6. So a physician performs a 4-vessel autogenous, meaning 1 venous and 3 arterial coronary artery bypass on a patient who had a previous CABG 2 years ago, utilizing the saphenous vein, radial artery, and then the left and right internal mammary arteries. So we'll go to CABG, or the coronary artery bypass graft, in the alphabetic index. Okay, so remember, we're doing every other one. So fill in the blank on this one: coronary artery bypass graft is where we're going to go in the alphabetic index. I'm flipping here myself. Underneath coronary artery bypass graft, we did arterial venous, right? Because we had 1 vein and 3 arteries. So we need 33517 through 33519, and then 21 through 23. So the 33517 through 19, and then 21 through 23. Those are going to be the coronary artery bypass using the venous graft and arterial graft. But if you look at the standalone portion of the code, or the indented portion of the code, sorry, it's going to be for your single vein graft versus 2 vein graft, 3 venous grafts, right? So this is the only one, or these codes are only going to be the vein component. So if our coronary artery bypass graft is with 1 vein, then we should use the 33517. So if we were testing, we've already got our answer because nothing else has a 33517, right? So if we're doing process of elimination, we've got our answer. But for the sake of going through and doing it so we can make sure, because CABGs are kind of difficult, let's go look at our arterial component, right? Because again, the 33517 is the vein component only of the combined arterial and venous. So if we go back in our index to CABG, or the coronary artery bypass graft, then you'll go to the arterial bypass. And then that sends us to 33533 through 33536. And then for the 3 arterial, so the 33533 through 36, we're going to use 33535. I'm just going to highlight those here too, so that way we can just kind of see what's what. Actually, no. I'm just going to highlight them in this one so it doesn't confuse. Okay. So now we have a patient who had a previous CABG 2 years ago. So this is going to be what's known as a reoperation. So in our alphabetic index, we'll go to reoperation, right? Because we had a CABG before, now we're having to redo it. So reoperation, coronary artery bypass, and that gives us 33530. And that's for a reoperation of a coronary artery bypass procedure or valve procedure, so either one, more than 1 month after the original operation. So that's our 33530. So next, we have the saphenous vein, the radial artery, and then the left and right internal mammary arteries. Some of these are going to be included in our CABG procedure, and one of them is not. So if we go back to our guidelines, you can either look at the guidelines for the artery only or the vein only, and they're going to be the same guideline. But either way, it says procurement of the artery for grafting is included in the description of the work for 33533 through 33536. And it should not be reported as a separate service or co-surgery, except when an upper extremity artery is procured. So the saphenous vein is in the leg. The right and left internal mammary arteries, those are in the chest. But our radial artery is in our upper arm. So our radial artery can be coded separately. And then your guideline continues on to say that to report the harvesting of an upper extremity, which is our radial artery, then we can use either 33509 or 35600. So 33509 is an endoscopic harvesting of upper extremity artery, one segment for coronary artery bypass procedure. And then 35600, we're going to have to flip a couple pages to get to that one. That is the harvest of an upper extremity artery, one segment for a coronary artery bypass procedure, open. So the radial artery is being reported as an open procedure. Now, if we're looking at this, we obviously knew what our answer was a long time ago, right? But why do we only have one procedure that has the modifier 51? Why are we not reporting the modifier 51 on the 33517 or the 33530? What type of codes are those? They're add-on codes. Yep. So remember, your add-on codes are not going to have your modifier 51, whereas 35600 is the only one that is not an add-on code, at least from a sequencing, right? The first one is an add-on code. Yep. Okay. Cabbages or heart? All right. And I just realized I didn't do the poll for six for the, yeah, Jeannie, cardio is hard. Okay. Number seven, physician changes an old battery to a new one on a patient's dual chamber permanent pacemaker. So what CPT code or codes are we going to report? So for this one, we have 33212 and 33213 are really close. And then we have 33229 and 228 that are really close. So let's go look at the 33212 versus 33213. 33212 is for the insertion of a pacemaker pulse generator only for a single lead. And then 33213 is for dual leads. For this one, we're removing and then upgrading, right? We're not just changing the battery. No, sorry. Yes, this one we are just changing because they're changing the battery to a new one. Yes, sorry. I was thinking of a different question than I have. But okay. So sorry, this is just insertion, right? So we're taking one out and we're putting one in. So the 33212 and then the 33213 are ruled in, right? Okay. So then let's go look at the 33228 versus 33229. So 33228 is the removal of a permanent pacemaker generator, pulse generator with the replacement of your pacemaker pulse generator for a dual lead system. And then 229 is a multiple lead. So we have the dual chamber and we're changing the battery. So it should be D for the 33228. So just make sure you're paying attention to terms and then whether we're inserting and removing, whether we're removing. Okay. So when we're talking about pacemakers, it can get a little muddy and a little fuzzy with all of the different ones. They can look very similar, but be very different procedures all at the same time. Okay. So it looks like everybody that answered got it right on the poll. So good job. So question nine. Sorry, we're question eight, not nine. Hang on. I clicked the wrong one. Question eight. Damn it. Okay. Question eight. Patient is diagnosed with an acute systolic heart failure due to hypertension with CKD, stage 4. So what ICD-10 CM codes? So we're going to do coding from scratch on this one. So we have heart failure due to hypertension and CKD. So if we remember from our guidelines, we have hypertension with heart failure and or chronic kidney disease. we can assume a causal relationship. So we have to go hypertension, and then we can do, you go down to with, we have heart involvement and then kidney involvement, right? So if we have both, then we need to go to cardio-renal, because cardio for heart, renal for kidney. So hypertension, cardio-renal, and then we have with heart failure, right? Because it's systolic heart failure. And then our stage of chronic kidney disease is stage 4. So we're going to go to the first option with stage 1 through stage 4. And that gives us I-13 for the hypertension component. Okay. So then if we go look at our I-13.0, because if you were just to look at your alphabetic index, you would probably think I-13.0 is going to include everything, right? But if we go to I-13.0, then we have the code additional, use additional code note that says that we have to identify the stage of chronic kidney disease and the type of heart failure. So we're going to have to code the acute systolic heart failure. We'll go to main term failure. And then heart. And then we have to go down to systolic. And it is acute. So that gives us the I-50.21. We'll go verify that in the tabular really quickly. That is acute systolic congestive heart failure. And then we need to code our stage of chronic kidney disease. So we'll go to disease as our main term. And then we'll go to kidney, chronic, stage 4, and that gives us N18.4. Okay. Let me get to question 9 on the poll. So question number 9, a PIC with a port is placed under fluoroscopic guidance for a 45-year-old patient for chemotherapy infusion by a physician. The procedure was performed in a hospital. So coding from scratch, we are doing a catheterization, because that's what a PIC stands for. It's a catheterization. It's a peripherally inserted. Hang on, I have to look at what PIC means. I knew it in my brain. It's a peripherally inserted catheter, centralized catheter. Okay. So we'll go to catheterization. And then venous. And then it is a central line. So it's sending us to central venous catheter placement. And then we are doing an insertion because it's being placed. It is central. It is a peripheral. So that's where where you're gonna need to know your medical terminology and some anatomy, not anatomy, med term as far as like your acronyms. And then we did do it with a port. So it sends us to 36570 through 36571. So 36570 is insertion of a peripherally inserted central venous access device with a subcutaneous port younger than 5 years of age. And then 36571 is 5 or older. So we've got the 36571 because we're 45. And then we need to determine, should we report, because we do have that fluoroscopic guidance. So do we need to report the fluoroscopic guidance separately? Or should it be included in the 36571? What do you guys think? Is there any mention in the code description or parenthetical notes or the guidelines that that the fluoroscopic guidance is going to be reported separately or included? There's no parentheticals about fluoroscopic guidance. And then let's see, I'm skimming through the guidelines here real quick just to make sure. Yep, there's not anything in the guidelines saying either way. So we can, from a testing perspective, we already know, right, that we need to use it. But if we're in the real world or coding from scratch, we're going to go to fluoroscopy because that's our fluoroscopic guidance. So we'll go fluoroscopy and then guidance. And then we're doing it for a venous access device. And then that gives us two codes, the 30,000 series code and then our 77001. We go look at our code description for 77001. Then that is fluoroscopic guidance for the central venous access device placement, replacement, or removal. And then because we are in the hospital, we have to report the 26 modifier to indicate that we're only coding for the physician and the professional services, no technical component. Okay. All right. Let's do very last one. Number 10. So the maze procedure is performed on a patient with atrial fibrillation. The physician isolates and ablates the electric path of the pulmonary veins in the left atrium, the right atrium, and then the atrioventricular annulus while on cardiopulmonary bypass. So to be totally honest, they're all right there together, right? So 332, 54, 55, 56, 59. There's not really a a trick on this one where since they're all right there together, we've just got to go see which one it would be. So 33254 is an operative tissue ablation and reconstruction of atria limited, which is also known as a modified maze procedure. 33255 is an operative tissue ablation and reconstruction of the atria extensive, which is a maze procedure without cardiopulmonary bypass. 33256 is with cardiopulmonary bypass, which we did do cardiopulmonary bypass, right? And then we did um, ablation and reconstruction of the atria, and then the atrioventricular. So it's going to be our 33256. Because it's our maze procedure. So that's our other indication. And then with our cardiopulmonary bypass. Okay. So let's stop the recording and then you guys can ask questions and I'll let you guys come off mute in just a second.